Okay. Good evening. Myself, Dr. Tabassum Sultana, final year postgraduate from Gandhi Medical College. My talking point is on the serological evaluation of acute encephalitis cases. Introduction. Acute encephalitis syndrome is defined as acute onset of fever and change in the mental status and/or new onset of seizures in a person of any age at any time of the year. AES is an emerging public health problem claiming thousands of lives, and the disease most commonly affects children and young adults and can lead to considerable morbidity and mortality. The disease spectrum of AES seems to be much wider and may be caused by a wide variety of viruses, bacteria, protozoa, fungi, or may even be non-infectious in etiology. Viruses are the most common and important cause of encephalitis. The frequency of specific agents varies according to geographic location, season, patient's immunological status, exposure to insects or ticks, animal bites, and viral genetic mutations over time. Encephalitis is an inflammation of the brain parenchyma associated with clinical evidence of brain dysfunction. Encephalitis should be suspected when symptoms or signs of neurologic dysfunction present acutely, along with systemic manifestations or with history of exposure to known risk factor. Early diagnosis can alert the clinician for timely initiation of specific therapy and prevent the high morbidity and the mortality which can occur in the absence or delay in the treatment. Aim to identify viruses causing acute encephalitis syndrome. Methodology, study design, hospital-based descriptive observational study. Inclusion criteria, patients presenting with fever of less than 15 days duration, with or without altered sensorium, seizures, headache, vomiting, abdominal pain, and paralysis. Exclusion criteria, patients suffering from bacterial meningitis, head injury, simple febrile seizures, heat stroke, space occupying lesion, metabolic disorders, and papilloedema. Sample size and duration of study. From January 2019 to December 2019, 366 serum or the CSH samples from clinically suspected cases of acute encephalitis syndrome attending Gandhi Hospital, Secunderabad were included in the study. IgM antibody detection by enzyme-linked immunosorbent assay for Japanese encephalitis virus, herpes simplex virus 1 and 2, and West Nile virus were done in the patient's serum, CSF or serum using commercially available ELISA kits as per the manufacturer's instructions. The ELISA kits used for detection of viruses causing AES for HSV 1 and 2 kit used was from Cal Biotech, and for West Nile Inbios International, and for Japanese encephalitis the kit was used from NIV Pune ICMR. Results: virus identification serologically was possible in 18.5% of the acute encephalitis syndrome suspected patients. Most common virus identified in AES suspects in our study was herpes simplex virus 24.2%, followed by West Nile virus 21.4% and Japanese encephalitis virus 8.1%. The positivity for viruses in patients suspected of acute encephalitis syndrome, out of 366 samples tested, 68 were positive. Total males included in the study were 164. Out of 164 males, 23 were positive, and total females included in the study were 202. Out of 202, 45 females were positive, and children included in the study were 127. Out of them, 34 were positive, and adults were 239. Out of 239, 34 were positive. The most common virus identified in AES suspects in our study was herpes simplex virus, followed by West Nile virus, and followed by Japanese encephalitis virus. Age-wise distribution: less than 50, 23%, 23 cases were below 15 years of age, and 12 cases were in the range for HSV. 12 cases were in the range of 15 to 30 years, and in 31 to 45 years age group, 10 patients were there, and 46 to 60 age group, 4 patients were there in the HSV positive. For West Nile, below 50 years, 4 patients were positive, and in the 15 to 30 years range, 3 were positive, and 31 to 45 years age group, 2 were positive, and 46 to 60 years age group, there was no cases of West Nile. Japanese encephalitis virus, 3 cases were positive below 15 years of age, 7 cases were positive in the range of 50 to 30 years, and 46 to 60 years age group, Two cases were positive for JE. Gender-wise distribution. HSV is more common in males HSV is more common in females, and West Nile, the gender-wise distribution was equal, both in males and females. Japanese encephalitis was most common in females. The clinical profile, the most common symptoms observed in AES suspected patients were fever, next altered sensorium, and 50% of the cases presented with seizures, followed by headache, vomiting, and abdominal pain were seen in only few cases. In 2017, Jitendra Kumar Tiwari et al. Study, most common virus identified in AES suspects was HSV, followed by EBV, followed by varicella zoster, cytomegalovirus, Ebola virus, mumps virus, dengue virus, measles virus, and respiratory and rhinovirus. In 2020, Berna Clean the Costa et al. Study, the most common cause of encephalitis was herpes virus, non-polio enterovirus, and arbovirus. Viral encephalitis is the most conclusion. Viral encephalitis is the most common cause of encephalitis in children and adolescents. All possible efforts should be made to establish the specific diagnosis using epidemiological information, clinical presentation, ancillary tests. The differential diagnosis is not restricted among different viruses, but also includes other infections and immune-mediated inflammatory CNS disorders like encephalitis and autoimmune encephalitis. All cases of all cases of acute encephalitis must be hospitalized with an access to intensive care unit equipped with mechanical ventilation. Patients with suspected viral encephalitis should be started empirically on acyclovir as early as possible. Supportive therapy for acute viral encephalitis is an important cornerstone of management. However, we need better antiviral therapy to meet the challenges of acute viral encephalitis more effectively. For better management of patients, it is important to know the profile of viruses causing AES in the given area so that immediate action can be taken before laboratory results are available. Prevention. The key to viral encephalitis is prevention. Vaccination and vector control measures are useful preventive strategies in certain arboviral and zoonotic encephalitis. Currently, vaccines are available against a limited number of viruses with the potential to cause encephalitis. Example, mumps virus, measles virus, rubella virus, polio virus, rabies virus, and Japanese encephalitis virus. Besides the personal protection against mosquito bites, CDC recommends the administration of JE vaccine to native and expatriate residents of endemic areas and to travelers staying a month or longer in endemic areas, especially rural areas during the transmission season. Travelers should wear protective clothing to prevent the mosquito bites, avoid outdoor activities where the risk of tick-borne infections is high, and insecticide spraying may help. Preventive measures against exotic forms of emerging paramyxovirus encephalitis, Nipah, and Hendra viruses are entirely environmental, such as sanitation, vector control, and avoidance.